So it's my pleasure to now introduce the third plenary speaker of this morning, who is Dr. Susan Whitfield-Gabrielli. And let me just tell you a little bit about Susan, for those of you who don't know Susan. Susan is the founding director of the Northeastern University Biomedical Imaging Center, and that's been a very recent move, in fact, since this summer. But she, as well as being professor of psychology at Northeastern University, Susan maintains her role as principal research scientist at MIT. And I think those of us who know Susan would say she would, I think, agree that she is one of the instrumental leaders in the development of very sophisticated brain imaging methodology, analytic techniques. And what is more, Susan has this sort of really kind of unique skill of bringing this highly sophisticated technology into clinical reality, so bridging the gap between high-level techniques into clinical practice. And what Susan's really going to be doing today is telling us about exactly the work in exactly that area, bringing together the neuroimaging methodology to help us understand how this can be useful clinically. And not surprisingly, because of this skill set, Susan is a highly sought-after teacher. She's won several teaching awards at her various institutes, and is also one of the most highly popular speakers at human brain mapping. So today it's my pleasure really to introduce Susan, and her talk is going to be focused on clinical translation of brain connectomics. So let's say thank you to Susan.
So thank you, Mary, for that incredibly gracious introduction. Thank you to Mary and Scott for the introduction, for the invitation to be here, and thank you for the entire organizing committee of SOBP. It's really an incredible honor and pleasure to be here today. I love this conference, and I'm really grateful to be here today. So I think we're facing a tremendous crisis in mental health in adolescents with psychiatric illness. In particular, we're facing a challenge with teenage anxiety and depression. And we all, many of us know this from personal experiences with family and friends or through our research in clinical practice. It's also reached the popular press. This is an example of a New York Times article indicating that the U.S. teens have suffered from severe anxiety, and why is that the case? These popular press articles are backed up by a lot of research. This is an example of a survey done over 50 years, over 150,000 freshmen at 227 four-year public and private universities, and what they found was that the freshmen self-assessment of their emotional health hit a recent 25-year low, and they found that women were twice as stressed as men. It's also the case that the U.S. suicide rates have surged to a 30-year high recently, where girls as young as 10 to 14 are committing suicide. There's a threefold increase in suicide with such young girls. There's a recent paper in JAMA Pediatrics indicating that there's a 100% increase in ER visits for children with suicidal attempts or ideation. As a personal anecdote, I have a 10-year-old child who I recently took into the Boston Children's Hospital because she had a severe asthma attack. And while I was in the ER, we stayed there overnight, I noticed that there were a lot of rooms who had armed guards. And I finally couldn't help myself, but I asked one of the nurses what was going on. And she said that for every room that had an armed guard had a child or an adolescent who tried to commit suicide or had suicidal ideations. And to me, that's a stunning experience. And that maybe that was an off night. But if you look at the numbers, I think that we're going in the wrong direction. So if we take a step back and think about what can we do in neuroimaging, how can neuroimaging help people with anxiety and depression and other psychiatric illnesses, we might find that we can do something useful. So we know that there's many challenges in psychiatric disorders. I'll highlight here a few in yellow, which I believe we might be able to help mitigate with neuroimaging. Detection is often done late, often done by crisis. The treatments are most often done by trial and error, despite the fact that we know there's great patient heterogeneity in treatment response. And as we know, treatments are often have negative side effects, only are partially effective, and have high attrition, as we know by the famous STAR-D study, which evaluated treatment of depression and found that 50% responded and 30% withdrew. So what about neuroimaging? We can look at brain structure and brain function, but today I'll talk about how the intrinsic structural or functional connectivity of the human brain is elucidated by diffusion-weighted imaging and resting state connectivity holds great promise for clinical translation. And I'll be focusing primarily on resting state networks. So where are we currently with neuroimaging and psychiatry? Well, we certainly know that the DSM grows thicker and thicker over the years, indicating more and more psychiatric classified disorders. And if you were to look up on PubMed a lot of these psychiatric disorders and you throw in MRI, fMRI, you may get about 20,000 hits. And these papers have been instrumental in providing insights into brain differences of psychiatric disorders. However, this knowledge has not fundamentally altered patient diagnosis or treatment, except for some rare exceptions, like the wonderful work with Helen Mayberg in deep brain stimulation or TMS. So how can we change this? Well, one way is we can use resting state biomarkers for early detection that could potentiate early intervention and possible prevention of disorders. We can use them for neuroprediction to predict clinical outcome. If we would be able to use these resting state biomarkers to predict which treatment one particular individual could get, then we can go towards precision medicine. And we can also use these resting state biomarkers and resting state networks in terms of identifying novel interventions like real-time fMRI neurofeedback. So today I'll talk a little bit, a very quick overview of resting state networks, and I'll talk about some of the functional associations between the default mode network and the self-reference network, and as well as some behavioral correlates, because I think understanding the associations of these networks may aid in interpreting what the functional pathology of the default mode network may mean in the case of neuropsychiatric disorders. But the core of the talk will really be in terms of clinical translation, clinical characterization, early detection, and neuroprediction. And then I'll wrap up the talk by talking about future directions and how we can use resting state networks in terms of novel interventions, or how we can use resting state networks in terms of looking at the effect of pharmacological or behavioral interventions. So it was back in 1995 that Bharat Biswal noticed that the regions of the brain that are highly temporally coherent to the motor cortex during rest look remarkably similar to the task activation that you would get when you're finger tapping. So the regions of the brain that rise and fall in temporal synchrony form these resting state networks that are intrinsic, spontaneous, very low frequency fluctuations in the fMRI bold that exhibit specific networks in the absence of any task whatsoever. And there's a lot of characteristics about these resting state networks that I think are clinically meaningful. The most important one, of course, is no task, so we can bypass the behavioral differences in task performance that we usually have as confounds in the fMRI task world. But they're also accessible to pediatric populations, including infants. So when we're talking about early detection, we can look at brain resting state networks in infants and follow them longitudinally, which we're doing. And it also makes it accessible to a wide range of clinical populations, including low-functioning ASD. Secondly, they're fairly reliable and robust, but importantly also plastic. So this allows us to look at the pharmacological and behavioral interventions and how those interventions may modulate these intrinsic networks. And thirdly, there's availability of high-quality, large cohort data sets. Many of us in the room, this is important actually for making it's key for creating very reliable models. We also know that there's human connectome projects, many of them now, starting with the initial HCP, but then there's a developmental HCC aging. Many of us in the room here, Betsy Line and Catherine Narr, Leanne Williams and I have been working really hard on the connectomes related for human disease and relation for depression. And of course, there's the monumental longitudinal ABC. So now we have all of these wonderful available high quality large cohorts. So we know there's many different resting state networks. So they'll be focusing on the default mode network that consists primarily of the medial prefrontal cortex, posterior cortex, and lateral parietal cortex. And here's an iconic figure by Fox and colleagues showing the default mode network as elucidated by resting state connectivity. Here, he had the individuals just lying in the scanner. He placed a seed in the PCC, and he looked at the temporal correlations of every other voxel in the brain to that seed. And what he found was a thresholded RMAP here at 0.3. What he found is regions of the brain that are anatomically remote, like the medial prefrontal cortex, are highly temporally coherent. So you can see the time course in yellow and orange for the PCC and MPFC, and they're practically superimposed. Whereas if you looked at the time course in a task-positive region, like the dorsolateral prefrontal cortex or dorsal ACC, you would see that time course is actually negatively or anti-correlated to the default mode network. And it turns out that the magnitude of these anti-correlations vary across time and people. And today I'll be focusing on the anti-correlations of the MPFC and DLPFC, because we and others have shown there's evidence that the MPFC, DLPFC anti-correlations are related to individual differences in executive function, like complex working memory, and they change over the lifespan. So this is an inverted U curve. So the anticorrelations selectively increase, as does executive function during development. And then unfortunately, they selectively decrease over aging, as does fluid intelligence. But importantly for this talk, there's a significant decrease in these anticorrelations in many psychiatric disorders with cognitive impairment. So I won't get in, I promise not to get into this too much, but there are many different challenges in interpreting these resting state networks. The two biggest ones is that because we're looking at very low frequency, we have to deal with physiological aliasing and respiration artifacts. And secondly, we have to deal with motion artifacts. So for those who are interested in this technological issue, I will say that in these data that I'll be showing you, we don't do global signal regression to address these physiological aliasing. We do instead an anatomical comp core method of noise reduction, where we take the brain, we segment it into gray-white CSF, we do a PCA decomposition on the white matter and CSF, and add those as nuisance regressors in the first level GLM. And we also regress out outliers in motion and global signal intensity. And we find that increases sensitivity and specificity of the positive and negative correlations, and this allows us to interpret the negative correlations, which we find important. So we've embedded these tools into a toolbox, and at first that was just to do ROI to ROI connectivity and NC to voxel, but now Alfonso has made many other possible analysis techniques, including dynamic ICA and a number of dynamic connectivity, and a lot of voxel and voxel, so you can do data-driven connectivity analyses like MBPA. So all of the resting state analyses that I'll be showing you here today have been analyzed in this toolbox. So what about the functional associations of the default mode network and the self-reference network? Here we did an empirical investigation looking at the DMN and the self-reference in the same subjects using the same baseline. So this is a block design where we had people looking at trait adjectives, and the self-reference task was to decide whether that adjective described him or herself. And then we had a pure rest, and then we also had a semantic baseline. So what you're seeing here is basically a conjunction analysis looking at the regions of the brain that are more active for self greater than semantic and rest greater than semantic. And what you'll find are that it's exactly the two core medial hubs of the default mode network that are implicated in self-referential processing. And this is important because you might find then, or you might infer, that if you have functional pathology in the two core medial nodes of the DMN in various psychiatric disorders, that may suggest a pathology in self-referential processing. We also know that in the healthy brain, the greatest suppression of these regions correlate with better memory formation, fewer lapses of attention, less mind wandering, and importantly, more mindfulness. So when you are doing mindfulness meditation, you're actively pushing down your default mode network, and that will come up later on in the presentation. So in general, the more these regions are suppressed, the better one can focus on the external world, and the better one can perform a task. So we also know that the greater medial prefrontal cortex and DLPFC anti-correlation is associated with superior working memory capacity. So to the right, you'll see a scatter plot. Each dot is a person, and you'll see those people who have more MPFC, DLPFC anti-correlations and negative correlations score better on a complex working memory or O-span. So that's kind of all background, but let's get to clinical applications and start with schizophrenia. We know schizophrenia is a severe psychiatric disorder characterized by disturbances of thought, perception, emotion, as well as neurocognitive deficits, and we know there's a genetic basis for it. So early on, we looked at patients with early schizophrenia, first-degree relatives of patients with schizophrenia, and controls. And what we found was there was a monotonic increase in the DMN connectivity from controls to relatives of patients. And it was precisely in the self-reference nodes of the DMN, the MPFC and PCC, where we had greater connectivity for patients and relatives compared to controls. Moreover, the degree to which the MPFC and PCC were correlated during rest positively correlated with psychopathology as measured by the positive symptoms, SAPS. So it's as if the MPFC and PCC in schizophrenia are hijacked. They're tightly correlated during rest, and that may generate paranoid ideations, delusions, and possibly auditory hallucinations, which we'll talk about at the end as well. So we also wanted to look at the anti-correlations. So we placed a seed in the medial prefrontal cortex here in blue. And when we did ANOVA, it was the right DLPFC where we saw that the controls had significantly more anti-correlations relative to the relatives and the patients, and that related to cognitive impairment. So that's all nice. We can use these resting state networks to characterize patients who are already diagnosed. But what about looking at resting state networks to identify brain vulnerability for illness before the onset occurs? We know that current treatments for psychiatric disorders are inherently reactive to suffering and incapacity. Why don't we try to do a proactive approach in which we can define the network pathologies before the children are ill? So we wanted to look at depression, and so we know that a child of a parent with major depression has a 3 to 5-fold increase for risk for developing depression. So in this study, we looked at 30 children ages 8 to 14. They had no current depression, but they had at least one parent with depression. We had age-matched controls with no parental history of depression. And we had the Child Behavioral Checklist, or the CBCL, as a behavioral measure, which records behavioral problems and competencies of children in 6 to 18 years of age, and it's highly predictive of psychiatric illness. Before I tell you about that, I did want to mention that if you think about the DMN resting state in adult MDD, we can look at Mike Grecius's finding that shows that there's increased DMN functional connectivity in the subgenual ACC, which we know is a region implicated in depression. So it's as if in adult depression, the default mode network ropes in this region that we know is implicated in depression as fewer glial cells, less metabolism, so on and so forth. And so this DMN ropes in the subgenual in adult MDD. Well, when we wanted to ask the question, does this DMN pathology in depression reflect the state of depression or the neurobiological trait? So when we looked at the children who were at risk for depression, they didn't have any clinical diagnosis whatsoever, and we placed the self-reference seeds of the DMN. We found that the kids at risk for depression had hyperconnectivity to the subgenual. In other words, they had significantly more connectivity from the self-reference DMN to the subgenual than the controls. And moreover, the degree to which the DMN roped in the subgenual significantly correlated with an increase in internalization, CBCL internalization, especially anxiety and depression. So here we have a profile that looks very similar to the adult major depression. So this could suggest that this is a neuromarker that may represent a biological trait of depression rather than a manifestation of the disease itself. We also placed the seed in the left DLPFC, and what we found here was that the left DLPFC was anti-correlated to the ACC, the subgenual ACC, where it wasn't so in controls, and this will come up in the future in the talk. And then we followed these children 3 years later, and we found that the baseline resting state connectivity predicted future conversion in depression better than conventional systems. So that was really looking at vulnerability, but we also, in collaboration with Ian Gottlieb at Stanford, wanted to look at what the markers of resilience might be. So here we looked at resting state connectivity markers of resilience in adolescents at families at risk for major depression. So that then brings us to the prediction. So there's been many famous people have recognized that prediction is very difficult, especially if it's about the future. And we find that's true also in neuroimaging. So we did a recent review where we looked at all the papers that suggested that neuroimaging can predict some kind of outcome. And we found 72 papers. 61 of those papers were actually just straight correlation. So as a field, I think we need to move from correlation to prediction. So training on one and testing on another. But now that we have these large data sets, it's much easier to do, or we could do nested cross-validation. Another phrase that comes to mind that seems appropriate here by Kierkegaard is life can only be understood backwards, but it must be lived forwards. This is a review by Tim Hahn looking at the predictive analytics in mental health. And what he shows here in his first figure is that we've gone from descriptive analytics, which is more hindsight, to group level inferences, which is more insight, to predictive analytics, to more foresight. And it's wonderful that we're going from, in general, from hindsight to foresight, but I would say that even the predictive analyses, even done correctly, are really post-diction, because we already know who actually it gets better. So what we need to do for the next step is go from post-diction to single subject prediction. So having said that, I was going to tell you about a prediction study, but I guess I should call it a post-diction study, where we looked at 39 medication-free patients with social anxiety disorder and 37 matched controls. The patients with social anxiety received 12 weeks of CBT training. We did a bunch of neuroimaging, and the clinical status was the Liebowitz Social Anxiety Scale. And the neuroimaging at baseline that we did prior to the CBD involved fMRI task activation to angry versus neutral faces. We looked at diffusion-weighted imaging, the white matter integrity of the inferior longitudinal fasciculus, and we looked at hypothesis-driven or seed-driven resting state analysis, as well as agnostic data-driven resting state analysis. And what we found was, well, for the first question was, what can the initial severity of anxiety tell us in terms of treatment response? Well, it turns out that the initial severity already accounted for 12% of the treatment response. So imaging may not add anything at all. Luckily, it did. We found a cluster, not in the amygdala, much to our surprise, but a cluster in the occipital temporal region whereby the activation to angry versus neutral faces positively correlated with clinical outcome. And then when we combined the fMRI activation with the initial anxiety, we went from accounting for 12% of the variance of treatment response to accounting for 41% of the treatment response. And that's nice, but that's fMRI task. So I think it's good to move away from task to get to intrinsic connectivity so that it has more clinical meaning. We can go younger and younger and younger. So here, we looked at intrinsic structural and functional connectivity. In the resting state, we did a hypothesis-driven, bilateral, anatomically defined amygdala seed-driven analysis. We know the amygdala is the most common brain locus of dysfunction and social anxiety. However, from the previous study, we learned that the brain regions associated with the pathophysiology of a disorder may not be those regions that predict treatment outcomes. So we know the amygdala is involved in social anxiety, but there may be other brain regions that predict outcome. So because of that, we did an agnostic, data-driven, novel MBPA analysis to look for treatment outcome. And then finally, we also looked at the white matter integrity of the inferior longitudinal fasciculus. And what we found was by combining the intrinsic connectivity measures with the initial severity, we accounted for 60% of the variance in treatment response, which substantially exceeded predictions based on the clinical measures at baseline. So here, remember that the initial LSAS was 12%. We're going from 12% to 60%. In other words, a 5-fold increase in treatment response. Wouldn't it be great to kind of combine early detection and prediction in a normative pediatric sample? Can we identify biomarkers early in life, even in children who are not at familiar risk, which predict their subsequent behavioral and clinical trajectory? So in this study, we did a longitudinal prediction of behavioral problems in a normative pediatric sample. We had 94 typical children scanned at year 7 years of age, and every year afterwards until 11. And then again, we looked at the CBCL, and we did pre-register our analyses. The first hypothesis was that the degree to which the MPFC and DLPFC is correlated at age 7 may predict progression of CBCL attentional problems. And we thought that because we know that MPFC and DLPFC anticorrelations are related to executive function. We know there's a selective increase in anticorrelations during development, and we know that it's significantly impaired in ADHD. So we actually did find that. So we placed a seed in the MPFC, and we found that baseline MPFC-DLPFC connectivity predicted worsening of attentional problems 4 years later. So the scatter plot's a little bit challenging to interpret, but each dot is a person. The x-axis is the worsening of attentional problems. So any person on the positive there is getting worse. If anybody on the negative x-axis is getting better. And so on average, children of 7 years of age actually have positive connectivity between the MPFC and the DLPFC. However, there's such great heterogeneity in that some people actually had anticorrelations at that age, and those who had anticorrelations got much better in attentional problems. Those who have more positive correlations got much worse in attentional problems. And you can see many people on the y-axis didn't change at all, and that's because it's a normative pediatric sample. So if you are a parent and you know that your child is more likely to potentially get worse in attentional problems or develop ADHD, then you might then suggest early interventions like behavior mindfulness interventions or exercise and so on and so forth. We also noticed that there's a weaker functional connectivity between the subgenual ACC and left DLPFC. Again, it's the same plot. The x-axis is getting worse and the negative x-axis is getting better. And this fits in with the literature. We remember that the kids who were at risk for depression did already have anticorrelations between the subgenual DLPFC. We know that Mike Fox looks at the subgenual DLPFC, finds the maximally anticorrelated region in the left DLPFC to target TMS to treat depression. And Hella Mayberg's work with deep brain stimulation in the subgenual ACC is also consistent with this. So we wanted to do a conceptual replication and extension. So we went back and looked at the children who were at risk for depression, who we followed for 3 years. And what we found is, again, weaker subgenual ACC DLPFC resting connectivity at baseline predicted subsequent worsening of anxiety and depression 3 years later. And we wanted to do another conceptual replication or extension even further. What about teens who are already diagnosed with anxiety and depression? What happens there? So this brings us to a human connectome and disease, or BANDA. This is a Boston Adolescent Neuroimaging and Depression and Anxiety group, where it's a longitudinal study with 225 adolescents, ages 14 and 15, who are already diagnosed with anxiety and depression. This is a partnership with MGH, McLean, and BU. And to the left, what you'll see in blue is where we show that the weaker subgenual ACC DLPFC connectivity predicted worsening of anxiety and depression 3 years later for people who are at risk for depression. To the right, you'll see a very similar map, and map is showing you that, again, that weaker subgenual ACC DLPFC baseline resting connectivity predicts worsening of anxiety and depression in those teens who already have depression and anxiety 1 year later. So we're continuing to bring back these people. It's an ongoing process, and so we're testing the model over and over as we bring these people back, and we're continuing to see that this kind of baseline connectivity is predicting worsening of anxiety and depression. So there's another large-scale longitudinal study that I just wanted to briefly mention. This is called the SHARP program. It's a longitudinal study of adolescents and young adults who are at clinically high risk for psychosis. This is conducted at the Shanghai Mental Health Center in collaboration with Harvard MIT. And we have 93 healthy controls. We have 158 clinical high risk. 23 of those, after we followed them for a year, developed psychosis, that's CHR. And then 135 did not develop a psychosis. And we have various measures like the SIPs. So remember, a decade ago, we showed that the degree to which the MPFC and PCC are coupled is correlated with positive psychopathology in early schizophrenia. And now that we have a much larger sample of clinical high risk, we can show here that the greater resting state connectivity, again, of these self-reference nodes predicts, now a formal prediction of a worsening of psychopathology in clinically high risk as measured by SIPs. And again, some of these people went on to convert, some of them did not. So we looked at the modular organization of the functional connectome, and we looked, and here to the left, you'll see the modular organization for the healthy controls. You can see the 5 major networks: central executive, metamotor, visual, limbic, and DMN. And you can see that the CHR negative, meaning those clinical high risk who did not go on to convert, they're qualitatively and quantitatively similar to the healthy controls, whereas the CHR positive, those individuals who did go on to convert to psychosis were qualitatively and quantitatively quite different. The SEG formed allegiance with the limbic as opposed to the sensory motor, and we also saw a 6 singular opicular module observed there. And this abnormal modular connectome organization at baseline was associated with a 3-fold increase in conversion. So now we've talked a little bit about early detection and about prediction. But how can we actually modulate these networks? There's a number of ways we've been doing this with pharmacological interventions. I'll tell you one about a behavioral intervention. And here's a schematic representation. At the top, we do a pure resting state. That's pure resting state as in A. And B, we do a functional localizer. So we localize individual, their default mode network and central executive network. And then C basically is this intervention. And this particular intervention that I'll be telling you about is a mindfulness augmented real-time fMRI neurofeedback intervention. And then finally, at D, we do another resting state scan. So this kind of schematic we use for assessing modulations of resting state networks for a variety of interventions that we're doing. So here we're trying to train schizophrenia patients to upregulate their central executive network and downregulate the default mode network. Judd Brewer has shown that mindfulness meditation significantly decreases your default mode network. So after trying this for many years, we finally were able to actually do this by training the patients with schizophrenia to do mindfulness meditation. We do that outside of the scanner. And then what we do is we basically, the experimenter tracks the bold signal from the central executive that we functionally localize, as well as the default mode network. And to the right here, this is fed back to the patients, but they're playing a ball game. And this ball game is basically a game such that you want to move the white ball up into the yellow circle, but you can only do that with your brain activation. So the white ball moves up when the DMN is lower than the central executive. So we want to push the DMN down and the central executive up. So the ball goes up a hop size proportional to the magnitude of the differences of the bold signals. However, if your brain is in a bad brain state, meaning your DMN is high and your central executive is low, the ball goes down to the blue circle. So they're playing this game and with their brain activation. And I'm going to show you an example. Usually when they come in, they can't do it at all, but they can. Most of them can learn it and they love it because they're finally in charge of their brain. Here's an example of one patient. So to the left, you're seeing the bold signal. The purple is a CEN. The green is a DM. He's unable to do it at first. The ball is moving up, though you can see that the DMN is going down, the CEN is going up. The ball goes up into the yellow circle. The yellow circle shrinks to make the task dynamically more difficult. And you can see that he's able to separate these bold signals. So prior to that intervention, we again found hyperconnectivity of the DMN and reduced MPFC, DLPFC anticorrelations as usual. But after that intervention, what we found was a reduction of the MPFC-PCC hyperconnectivity, we also found a reduction of the MPFC-DLPFC connectivity, meaning an increase in anticorrelations. So initially, they didn't have any anticorrelations, but after that intervention, they did see the anticorrelations, as well as MPFC dorsal ACC anticorrelation. So here we have a modulation of the resting state networks due to that real-time intervention. However, there could be a real potential confound here. So we could be just finding a mechanism of mindfulness meditation. So what if the real-time fMRI feedback had nothing to do with anything? Maybe we're just looking at the change of resting state connectivity based on the fact that they were just doing mindfulness meditation. So then we had a sham or motor control feedback. So rather than feeding back their DMN and CEN or the difference between them, we fed back the motor cortex. And then we did a pre-post test on the resting state to see if we saw resting state modulations in the networks that we were interested in. And as to the right in B, you can see that there was no change in the DMN in both in positive correlations or anti-correlations. So we conclude there that we need the mindfulness and we need the real-time fMRI feedback. If we do the mindfulness alone, we don't necessarily get the visual feedback, so we don't know how well we're doing. And when I talk to the patients and even controls, they find it very liberating to be able to see exactly when they're able to decrease their DMN and move that ball. So most importantly, this resulted in an attenuation of auditory hallucinations, and the degree to which the DMN connectivity reduced positively correlated with the reduction of auditory hallucinations. So I'll stop there and say that in the future, could children get help before they're in crisis through early identification, get treated more effectively with better precision to available therapies and have options for more novel therapies? And could human brain mapping and resting state connectivity help facilitate a path that will guide our children to happier, healthier lives? So I wanted to thank my mentors, Judy and Danny are right here, it's wonderful, and all of my fabulous clinical collaborators, as well as all of my wonderful colleagues, both at MIT and Northeastern. So thank you.
Wow, that was a tour de force. Thank you, Susan. We have time for one question.
Thanks for a great presentation. I had a question about the use of oh, sorry, I didn't see that.
Oh, thank you. Thank you. I just wondered if you're looking at early interventions after the fact. What if you did this with children just to establish something which I think is missing in the field, which is the baseline of all children? If you could figure out the baseline of where children are beginning from, you would identify these kids sooner.
You mean, can we go earlier in terms of identification? And that's exactly what we're doing. So we've collected a few hundred infants, and we're looking at the resting state networks of the infants, and we're following them longitudinally, see if we can track the behavioral and clinical trajectory of those infants, so we can do earlier and earlier behavioral interventions.
Isn't this like Jerome Kagan with his first study years ago? Thank you.
Sure.